I'd like to start by thanking AMMF and the conference organisers for inviting me to present some of the data analysis we've been working on that looks at diagnostic routes and rates of treatment cholangiocarcinoma for patients in England. This has been a collaborative effort from many different people across different organisations, and I'm presenting today on behalf of several colleagues shown on the slide whom I'd like to acknowledge and thank for their input. The AMMF has instigated a series of data analytics projects aiming to develop a robust evidence base around the epidemiology, clinical care and outcomes of cholangiocarcinoma patients, understanding that high quality data is needed to drive improvements in care and patient outcomes. This work's been conducted in partnership with Health Data Insight and the National Disease Registration Service at Public Health England, who collate and maintain a national dataset of registrable cancers in England, going back over many decades. An initial phase of the work between AMMF and NDRS considered the incidence and survival outcomes of cholangiocarcinoma patients, making several important findings, which are in the process of being written up into a manuscript. One of these findings was that of geographic variation in survival rates of cholangiocarcinoma. In order to build on this finding and hopefully provide further context as to the occurrence and reasons for variations in outcomes, we've been undertaking an analysis to look at geographic variation in both routes to diagnosis and a first definitive treatment for cholangiocarcinoma in England, using the National Cancer Registration data and associated datasets. As I'm sure many of you are aware, cholangiocarcinoma is typically asymptomatic in early disease, meaning that many present late and leaving them with fewer treatment options and a poor prognosis. This likely contributes to the fact that around 50% of patients have been shown to get diagnosed through an emergency route, a significantly higher proportion than seen for cancers generally, where 20% only are diagnosed via emergency presentation. The only potentially curative treatment for cholangiocarcinoma is resection, but this is only possible in the event of early stage or localized disease, representing a minority of patients diagnosed. And for those who cannot undergo surgery, treatment options are predominantly limited to chemotherapy to relieve symptoms and prolong survival. And stenting may also be an option to alleviate symptoms of jaundice. As a result, survival rates of cholangiocarcinoma within a year of diagnosis are estimated to be as low as 26% overall, decreasing to 17% when considering those diagnosed as an emergency. The current study used data from several datasets that are collated and maintained by the NDRS at Public Health England. Registered cases of cholangiocarcinoma and patient and tumour characteristics were taken from the National Cancer Registration dataset. This data from the Systemic Anti-Cancer Therapy dataset, or SACT, and hospital episode statistics were all used to define routes to diagnosis and/or cancer treatment. We initially defined a national cohort of individuals with cholangiocarcinoma as those diagnosed between 2006 and 2017 with either intrahepatic or extrahepatic bile duct carcinomas and other and non-specified malignant neoplasms of the biliary tract of any morphology, or liver cancers with a cholangiocarcinoma morphological code. The first recorded diagnosis of this kind during the period of interest was used. And for these individuals, we extracted some key demographic and clinical information. Now, this included age, sex, deprivation, other comorbidities, including liver disease, year of diagnosis, tumour subtype, and morphology. The Charlson Comorbidity Index looks for conditions such as diabetes, cardiovascular events, dementia, and COPD up to 27 months before and 3 months after diagnosis, giving a score that increases with increasing number of comorbidities present. And the Charlson Index and both underlying liver disease were both based on inpatient hospital data. And geography was captured through the Cancer Alliance of Residents at Diagnosis, and this was the main predictor of interest in our analyses. So firstly, considering the geographic variation in either 2-week wait referrals or emergency presentation route to diagnosis. Using the established routes to diagnosis algorithm, people were defined as having one of the following diagnostic routes. So a 2-week wait urgent GP referral for suspected cancer, emergency presentation, other GP referral, other route that includes inpatient, outpatient, or death certificate only, and a not known diagnostic route. For the purpose of this analysis, we were primarily interested in the proportion of diagnoses that were made via a 2-week wait referral and the proportion that were diagnosed via an emergency route, and these are the two endpoints that are considered particularly. 2-week wait referrals are a measurable standard and speak to the recognition of possible cancer symptoms in primary care and the appropriate onward referral for investigation, whereas emergency presentation is a suboptimal route to cancer diagnosis. We describe these outcomes overall and for each cancer alliance to understand crude variation by geography. In order to assess any role of geographic variation after adjusting for differences in case mix in the different areas, we performed linear probability models for each outcome, including the cancer alliance and the patient and tumor characteristics on the previous slide as predictors. The results of these models will be presented using funnel plots, which help us to identify whether cancer alliances are outliers from the average. We included 23,630 people with a cholangiocarcinoma, just over half of whom were female. Approximately half were younger than 75 when they were diagnosed with cholangiocarcinoma, and 3/4 had no comorbidities, according to the Charlson Index. 3/4 of cancers were intrahepatic cholangiocarcinomas, with just under 20% being extrahepatic, and the proportion of diagnoses in each year was higher with later calendar year. When we look at the routes to diagnosis categories in this group, we see, as in previously published data, that half are diagnosed via an emergency presentation route, whereas only 14% are diagnosed via a 2-week wait referral. When we look at how this breaks down over the time period of interest, we see that the proportion of diagnoses made via a 2-week wait doubles between 2006 and 2017, from just 10 up to 20%. There's also a small decline in the proportion of diagnoses made via emergency presentation, 51% to 46% over the same period. The bar graph shows the proportion of cholangiocarcinoma patients diagnosed via a 2-week wait referral in each of the 21 cancer alliances in England. And we can see that this varied from 8% to 19%, an overall range of 11%. On the right, we now have a funnel plot showing cancer alliance variation, adjusting for characteristics listed at the bottom of the slide. Each dot is an alliance, and the y-axis shows the percentage point difference from the average proportion of people diagnosed via a 2-week wait referral across all alliances. The horizontal black line marks this average probability, and so has a difference of 0 on the y-axis. Cancer alliances are ordered from left to right by the sample size, with the smallest number of people in an alliance on the left of the graph. The dashed lines show the statistical significance thresholds, and any cancer alliance situated outside of these thresholds are considered to significantly vary from the average, and we would refer to them as outliers. As you can see from the fact that there are a number of cancer alliances either above or below the significance threshold lines, we're seeing evidence of statistically significant variation in the proportion of diagnoses made via a 2-week wait referral route across cancer alliances in England. And there's a maximum difference of about 5% and above and below the average in the proportion of 2-week wait referrals in an alliance. The emergency presentations route, we see larger variability with a 19% range in the crude probability of emergency presentation across cancer alliances, from 38% to 59%. Again, the variation appears to remain after adjustment for the same characteristics. There are fewer outlying cancer alliances below the average, but there are certain cancer alliances with large percentage point differences from the average. As a point of interest, when we look at to see whether those alliances that have lower 2-week wait proportions have higher proportions of emergency presentations, we don't see any obvious correlation between the two diagnosis routes. So to summarize our routes analysis, half of people with cholangiocarcinoma were diagnosed via emergency presentation and only 14% via a 2-week wait referral. The proportion of 2-week wait referrals increased over the time period, whereas emergency presentation decreased. and there was evidence of statistically significant variation in both emergency presentation and 2-week wait referral routes that did not appear to be correlated. And moving on to look at our analysis of first definitive treatment. For analyses of treatment variation, the initial cohort was restricted to those diagnosed between 2014 and 2017 when cancer treatment data completeness was high. We also excluded those diagnosed only on the death certificate, as these people would not have had the opportunity to receive treatment. All data sets were searched for the first occurrence of curative surgery, systemic anti-cancer therapy, which I'll refer to as chemotherapy, or the insertion of a stent. The first of 4 outcomes of interest was the probability of curative surgery in the 12 months following diagnosis. And in those who did not receive curative surgery, we looked at the probability of chemotherapy, the probability of stent insertion, and then the probability of either of those treatment modalities. Today, I only present the findings for the first 3 outcomes that are shown in bold on the slide. And the analysis methods were then similar to those for routes to diagnosis, with linear probability models to adjust for other factors, which for this analysis also included route to diagnosis. After applying the restrictions mentioned in this analysis, we had just under 9,000 individuals with largely similar characteristics to that in the previous analysis. A slightly higher proportion were classified as intrahepatic, and there were slightly more comorbidities. This slide shows a breakdown of the treatments received by this cohort. In total, 13% received curative surgery, either alone or in combination with other treatment. 18% received chemotherapy, either alone or with a stent insertion, shown in the both pink and purple bars. 20% received only a stent insertion, but 50% received neither surgery, chemotherapy, or stent insertion that we could find evidence of. To look at treatment options for those who did not receive curative surgery, after excluding these, we saw that 43% received either chemotherapy or a stent insertion, which breaks down to 20% who received any chemotherapy and 28% who received stent insertion. Looking at differences in the probability of curative surgery across the cancer alliances, there was only a 7% range from 9 to 16%. Looking at the adjusted differences obtained from regression models, however, a few cancer alliances did appear to be outliers from the average, with 2 alliances lower and 1 higher than the statistical significance thresholds, and a maximum difference from the average probability of surgery being around 5%. The lowest probability of chemotherapy in any alliance was 13%, and the highest probability of chemotherapy was 30%, giving a range of 17. After adjustment, a few cancer alliances appeared to be outliers, but the majority of alliances fell within the statistical significance thresholds. And finally, there was large variation in the unadjusted probability of stent insertion across the cancer alliances. The lowest probability of stent insertion in any alliance was 16%, compared to a maximum probability of 42%, and this is a range of 26% across all alliances. And this wide variation remained after adjustment, with many cancer alliances considered outliers and differences of up to 15% from the average across all cancer alliances. So to summarize our treatment analyses, only 13% of those diagnosed with cholangiocarcinoma received curative surgery within 12 months. And of those who did not receive curative surgery, 43% received either chemotherapy or an insertion of a stent. A few cancer alliances were considered to be outliers in the probability of curative surgery or chemotherapy. There was much larger variation in the probability of a stent insertion by cancer alliance of residents at diagnosis, both in terms of the number of alliances marked as outliers and the deviance from the average probability of stent insertion in England. We've performed a number of sensitivity analyses, which I won't present here today, but will summarize briefly. So the time windows for the treatment endpoints were expanded to check we weren't missing significant numbers of treatment events. Data on stage and performance data at diagnosis were also extracted from the data sets, but found to have high levels of missing data. 45% had unknown stage at diagnosis, so we performed a sensitivity analysis to try and adjust for the effects of stage, but restricting just to the cohort of people with a known stage. Unfortunately, due to 3/4 of people missing performance status information, we decided not to try and adjust for this in any analyses. And finally, we stratified our analyses by tumour subtype to determine if there were differences for intrahepatic compared to extrahepatic and other cholangiocarcinomas. These analyses did not alter our main conclusions and in some cases confirmed our assumptions, for example, in terms of time windows for treatment. So to conclude, the wealth of data available through Public Health England means we're able to build up a strong evidence base on a national cohort of people diagnosed with cholangiocarcinoma and show where variation exists that could drive action to reduce inequalities in care. There are, however, some caveats of routinely collected data, one of which being that reporting delays meant we were only able to define routes to diagnosis up to 2017 at the time of the analysis. 45% of this cohort were missing stage at diagnosis, despite this information being combined from both trust submissions and pathology data feeds. This proportion of unstaged cancers is lower than seen for many other tumour types in the registry. For example, pancreatic cancers have close to 80% stage completeness since 2015. Whilst it's likely this information is known for the purposes of care, it does not appear to be flowing through to the National Cancer Registration dataset. So finding ways to improve this data collection would be a big step to improve the quality of the evidence base on cholangiocarcinoma and understanding inequalities in outcomes. Whilst we've been able to account for many differences in patient characteristics, we can't be sure that any variation observed isn't due to other differences in case mix that we haven't accounted for. I've already mentioned stage and performance status, but there are also potentially other factors not captured in the data, such as patient choice. This is perhaps most relevant for the treatment analyses performed. The large variation in stenting observed may still be explainable by the clinical presentation or case mix and different in alliances. Stent insertion is not going to be necessary for all individuals. However, the fact that similar differences were not seen for either surgery or chemotherapy, and that this is a highly specialized procedure, means that this observed variation warrants closer scrutiny. We saw that 50% of the cohort did not receive chemotherapy, surgery, or a stent insertion. This is comparable to rates already published for liver and intrahepatic bile duct cancers, and upon investigation, 80% of the cohort with no evidence of those treatment modalities died within 6 months of their diagnosis, which is likely a contributing factor to this. We also observed variation in the proportions of people diagnosed via emergency presentation and 2-week wait referral routes. Asymptomatic early-stage cancers and symptoms such as jaundice that are not specific to cancer can create difficulties for diagnosing cholangiocarcinoma and likely contributes to a high proportion diagnosed via an emergency route. The increasing proportion of 2-week wait diagnoses over time is encouraging. Combined with the presence of the geographic variation may mean that there is scope for knowledge sharing of good practice to further improve understanding of symptoms and diagnostic pathways. And finally, we're in the process of finalising these analyses and writing a summary report, which will be written up into a manuscript for publication in due course. Thank you for listening.